Hello, I'm Jack Braha, your host of Medcast Plus. On the show, we feature local healthcare providers and physicians to educate us on various medical conditions and provide us with some very helpful health tips. Today, we welcome Dr. Steven Pulitzer, Chief Medical Officer at New York Health and Hospitals Kings County Hospital, which is here in the heart of Brooklyn. Dr. Pulitzer will update us on how he is helping to bring state-of-the-art care to NYC H&H Kings County Hospital, something he refers to as Kings County 2.0, which I thought was a great title for today's show. And while we're not going to talk about a specific medical condition today, Dr. Pulitzer is going to talk about the advances and all the great things happening at Kings County Hospital here in the heart of Brooklyn. Dr. Pulitzer, welcome to the show.
Thank you very
Great
much,
to have
Dr.
you
Braha.
here to talk about one of our county's oldest institutions, greatest institutions, providing health care for the large, vast portion of this county, and sometimes some of the most difficult cases, unfortunate patients come to your hospital. So, welcome.
Yes, thank you. Thank you for having me on the show.
Thank you for being here for all the population of Brooklyn. And as I started off the show with Kings County 2.0.
Yes. So
what does that mean?
So Kings County 2.0 is the new way that we are able to provide health care to a population that has very few resources. A number of our patients have a lot of social determinants of health, which is a buzzword these days, and really have barriers to receiving great care and being able to continue with their care plans and care treatments due to some of these barriers. And
so some of these barriers, for the viewers today, what do we mean by social determinants? Right, it's a buzzword.
Right.
We see politicians talking about social determinants. We see the news talking about, but what it really means for us as doctors is something is blocking this patient. Something is causing something with this patient not to be able to get what we would consider the standard or the best health care available to them.
Correct. So there's patients who have food insecurity or housing insecurity or street homelessness, patients who have undocumented immigration status and are not able to get insurance. There's a lot of barriers that people will have in order to first make it to the hospital and second be able to receive the resources that we can give them and continue on in their own, if they have a home to live in their home.
Right. We talk about this a lot, and as you and I, when we were training and we were residents on the floor or the ward of the hospital, we'd be going down the hallway, and every now and then there would be a patient who came in for what you and I would have thought was not an emergency or something that you didn't need to come to the ER for. For example, we used to admit patients who ran out of medicines.
Yes.
But we would admit people who ran out of food.
Yeah.
They didn't have a place to live. And while it wasn't something I was trained in medical school to fix, this is a huge medical problem,
Yes.
healthcare issue in our county and across the country. Despite a booming economy and all the great things that we see with jobs and people getting work, there is still a population out there who needs Kings County.
Correct.
Needs a hospital somewhere. And admitting them is probably the easy part. We have an emergency room. You bring them on in. And you have a great emergency room at Kings County. I mean, you guys can handle anything, really, right?
Yes.
But it's a busy ER, I'm assuming, because of some folks that come in because of social determinants.
Correct. We have a lot of patients who are high utilizers of our ER systems.
Meaning they keep coming in.
They keep coming in repeatedly, and oftentimes, I think if we're going to differentiate Kings County 1.0 from 2.0, we wouldn't really pick up on the fact that this is a high utilizer. We would move them through the system. Perhaps, as you're saying, they don't have medications. We'd admit them. We'd try and get them out in a couple of days, and just it would be a cycle. They would be coming back.
It was a vicious cycle. I trained at Maimonides, not too far from you. It was the same situation. We knew the frequent flyers who would come to the ER, but that's a problem.
Right, and so when you sit back and you ask somebody, well, why are you coming today? What is it that's really making you come here today? And they say, well, I ran out of food, or it's cold out and I don't have a home, or I don't have a place to go, or simply very, very basic things like that. And no one's really taken the time to sit and ask them, you know, what is it that you need? And unless you are screening for something like the social determinants, you may not pick that up.
We're just pushing the paper.
Correct.
That's what we used to do a lot of is, patient came in and said, I have diabetes, and the sugar was a little bit high. The ER would admit the patient for uncontrolled diabetes, but the real situation for the patient was every time we gave them a prescription to go home now, we got the sugar normalized in the hospital, and we sent them out with paperwork, but they couldn't fill the prescription. So these issues, to me, are really important. I think it's very easy for me to stop GI bleeding. It's very easy for me to go take a polyp out of someone's colon. That's easy. Here it is, take it out, remove it, they go out the door. But what you're talking about with Kings County 2.0, the next step in preventing patients from suffering from these social determinants of care, whether they need a place to live, need a meal, help getting their medications, you can reduce the clutter in the ER, the clog, the backlog in the ER by discharging people safer, better.
Yes, absolutely. And to go with your example of a patient who's diabetic, we would do exactly that. We would have a patient come in, we would tune them up, we would send them out, and when they left, their sugar was perfect. They were eating well with us. Everything was fine. 2 weeks later, they're coming back. So we now have a screening tool that helps us to identify patients who may not want to make that, tell you right off the bat what's going on with them, and that they need a different kind of care. We have developed, and this also goes to the 2.0, our structure now is a multidisciplinary clinic where we have social workers, case managers, care managers, dietitians, we have a bariatrics team, and we have a kitchen, and we have an endocrinologist that all share in one space. So when we find somebody who is coming back to us a few times, their sugar is really not being controlled, they either have type 1 or type 2, we send them to our diabetes boot camp. And at the diabetes boot camp, it's a 90-day course. There's education. We have a kitchen. We teach them how to cook. And we have something that's very unique now is that we actually have a food pharmacy. So I can write a prescription for somebody and say, here, go down one level, and they can go shop in our pharmacy and get the healthy food that they need, and they can come back as often as they need.
Does this cost them anything?
No.
This is incredible, right?
Yes.
This is game changing. This is 2.0.
Yes.
So this is the transition from 1.0 to 2.0 is very difficult, but you've obviously been able to do it. Comprehensive care to now give the patient a hug and say, hey, listen, you're walking out the door with your sugars under control.
Right.
We're going to keep you at it.
Correct. And I think that the biggest paradigm shift is how you view public health. It used to be thought that our job was simply ending at correcting the sugar and sending them home, but really, like we're a large trauma center. And to give a different example, a young person comes in who's ambulatory, they're undocumented, they have a job delivering food. They get hit by a car, they break their leg, and they can no longer ride their bicycle, right? They live on the 3rd floor of a walk-up, and now they have a big rod in their foot, and they can't ambulate. So our job used to be, okay, we fixed your leg, and now you can go back home. But how does that person get upstairs? How do they get to the food that they need? How do they fill their prescriptions? Who is going to check up on them in 2 days or 3 days? This is where that paradigm shift is, because that's the help they really need. They need that first couple of weeks.
This is where the social worker team that you mentioned comes in, the interdisciplinary team. I think it's sort of one of the, I don't want to say undervalued or under-recognized, I don't know what the word is, but these are the most important people when it comes to continuing what the doctors do in the hospital. So, as physicians, radiologists, I'm a gastroenterologist, we're good at diagnosing, we're good at treating things, but what is that continuity of care after? How are we sure that patient's able to do what we recommended? And the social workers are so important. In the hospital, I don't even think we have enough of them. I don't think we could ever have enough of them, because every patient could probably benefit from their own.
Yes.
And so you have that team available to the patients at Kings County, that you're not just sending someone out with a brace who can't walk to try to get up to the 3rd floor walk-up apartment. There's some plan in place to help and support this patient. Even undocumented, even without the means to pay, without insurance, we can still provide that in this city.
Correct. And that's a great segue. We have what's called DISRIP partners. And They're partners.
Yeah, explain this DSRIP.
Yes, DSRIP.
DSRIP, we call it in medicine, in the healthcare community.
Right, and so it started a couple of years ago with an incentive to get health systems to work closely with their aftercare partners. So there's financial incentives if you can keep people from coming back into the hospital, keep people from having readmissions that they shouldn't be having. And it really made us think, well, how are we caring for our patients? What happens when they go home? Where are they going? So we have things like something for H&H is called at home. So if you need to be seen at your house and you need some antibiotics or you just need a checkup, we can send somebody directly to you. We will send the care to you and the care that you need. So,
yeah, the DSRIP program and these other types of programs that are going on across the country have really been what we lacked in healthcare before, which is taking care of patients beyond the doors of the hospital, beyond the doors of the office. That while there are many patients out there who are able to follow every instruction of the doctor, take their medicines, there are folks out there with challenges, and this could be language, it could be disabilities, ambulating or getting to the doctor. So this patient-centered home or taking care of the patient at home is a very big and newer development. It's not entirely new because I think doctors started making house calls 150 years ago. Or in Brooklyn, I hear stories from some of the doctors who have a little bit more gray hair than you and I both.
Yes.
Tell us how they used to make house calls, and now there is some, I guess it's government or some other incentive financially to help with this.
Correct. And what's very interesting is that there's a movement now for complex care of patients, and especially patients who become high utilizers in the system. And they've actually dialed the clock back. They've wanting to have one physician take care of that patient through all of their needs and visit them at home and see them if they come into the hospital. And so they're really finding that one-on-one care is really how these patients are able to follow up.
Yeah, I think a lot of us as medical students, or even before, that's how we envisioned the old, was it Marcus Welby,
yes.
Type of healthcare. That I envisioned myself. I was an EMT before I became a doctor, so I saw what went on in the home.
Yes.
So I think I had a unique ability that a lot of us don't get in our training as physicians.
Yes.
And whether that's intentional or unintentional consequence of how we train, seeing a patient's home can really change things for a doctor. I spent, when I was training locally in Brooklyn at Maimonides, I elected to spend 1 month riding with the ambulances at the end of my residency.
Wow.
And it is a lot different, as you mentioned, at home for the patient and in the hospital. In the hospital, it's well controlled.
Right.
So you have a program that allows folks to be treated at home sometimes when they need, get antibiotics at home, sometimes intravenous, I'm assuming they can get treated, to help keep them out of the hospital. Or more importantly, the ER, where we're always worried about the wait and troubles. Tell us about Kings County 2.0 from a technology standpoint. We were chatting before the show, state-of-the-art software.
So we firmly believe, and this is the senior leadership at Kings County, that everybody deserves the same level of care that you would have at the university hospital that has the latest and newest technology. A lot of the technology doesn't run itself. It's the protocols that you put into it. And the protocols really don't cost anything. So if you want to treat patients with the best standard of care and you adopt the protocols from really strong institutions, we are able to show that our outcomes are improving. By doing that, we've now introduced some new physical equipment to keep up with that. And so we have a surgical robot. Our new robotics program went live in January.
We had your urologist on the show, Dr. Weiner.
Yes, Dr. Weiner. He's been spearheading it, and he's done almost 40 cases since.
And so for the viewers, these are not self-driving robots. These are not self-driving cars. There's a surgeon operating the robot.
Correct.
So you have the robot that's being used by the surgeons.
We also have the only 3 Tesla magnet in the health system. And it's as Dr. Silvers was saying, there's mapping programs for neurosurgical care. We do a lot of brain tumor surgery, and we map out pre-surgical. We also, with the prostate imaging, we do the same thing that he was describing.
And we're talking about, for the viewers, 3 Tesla, meaning the type of MRI.
Yes.
Very fancy equipment, very expensive and fancy equipment.
Yes.
So you have You have that at Kings County.
Correct. And so we've really accumulated not only the equipment, but the protocols and the staff, and we're really reinventing how we're giving the care at Kings County. And if you walk into the hospital, you just feel that vibe from the first person you talk to. We try to involve housekeeping and dietary and the clerks, and everybody is a part of someone's care. They all have a role, and if you walk into a place and you feel welcomed and you can relax and you can take your anxiety away, you can actually receive better care, and that's what we're promoting.
Yeah, you and I probably have both been to many, many hospitals in our careers, and sometimes you get a vibe. Mm-hmm. It's like when you go to a restaurant and if the bathroom's dirty, sometimes you don't want to eat there. So
Exactly.
The same with hospitals, and
Mm-hmm.
you're what we call a chief medical officer
Yes.
of Kings County, and that doesn't mean that you're the doctor seeing every patient, but
Correct.
tell us a little bit about what the CMO, Chief Medical Officer job is in terms of quality of care and making sure that people are up to par. Tell the viewers what a CMO is. Many people probably have never heard about the type of job you have.
I can honestly say before I took the job, I really didn't know what the job was either. And so being the chief medical officer is being in charge of all the clinical practices and services that are provided at the hospital, how you will provide those services and how you will have the patient experience those services. In conjunction with the CEO and the chief nurse officer, the three of us really set policy for the hospital of how we want the care to be delivered.
So you're at the head of the medical care. Yes. So when we look at statistics and numbers, you're able to tweak the machine there to improve outcomes.
Yes.
And it's very important for patients to realize that, the hospital is a machine. There are multiple parts to the machine. It's not just the nurse and the doctor. We talked a bit about social work. We talked a bit about the home care that you're able to provide. Let's talk a bit about getting into the hospital. Mm-hmm. Emergency care.
Yes.
When somebody has an emergency or they feel it's an emergency, they end up in the ER. And some patients are what we call admitted, mm-hmm. and others are discharged. For the folks who come into the hospital, we understand how that works. We talked about that a little while ago. What is the health network available to patients if they're discharged from your hospital, say with a bellyache or with an eye problem, and they're given the paperwork when they leave the hospital? What is the safety net for them? What's the next step? Is there a comprehensive care program available outside of the walls of the hospital?
Correct. So that's a great question. That type of follow-up is really what is going to close the loop. And what I mean by closing the loop is the patient's care is not finished from the emergency department until they show up at the clinic that you're sending them to. And so we're putting together a group of navigators to make sure that patients actually show up for their appointments.
Explain sorry to cut you off there.
Sure.
What is a navigator? We hear this at a lot of hospitals now.
Yes.
It's not someone directing the cars or the ship. Tell us what a patient navigator is.
So patient navigator is really key to modern medicine, I think, because it's very complicated, especially as a new patient, to find your way to the right floor, to find your way from the parking lot to the elevator to where you need to go. And if you can't find it, there's nobody to call. There's nobody named Steve.
You give up and go home.
Exactly.
Right.
So we're starting a program now where we're for certain patients, we will assign a navigator that somebody has a name, they have a number, and that we will follow up to make sure that they got to their appointment okay.
They leave the ER, they're given an appointment, say they scratched their eye.
Yes.
Okay, so they got poked, but there's no reason to stay in the hospital.
Correct.
So someone's able to help coordinate their follow-up so they're not lost.
Yes, and we can actually track whether they've showed up or not, especially if we think that is something that needs to be seen within 24 or 48 hours. So we do this both electronically and with a physical person, like sort of dialing it back, going back to the Marcus Welby. But.
So we spoke a little, you mentioned electronically, so medical records, mm-hmm. the good old days of signing a note, drawing pictures on the chart of the area of the leg that we were concerned about and leaving a paper inside the folder is gone.
Yes.
Everything is computerized. I access my patient's records from my phone, from my laptop. So in the ER, they're using an electronic medical record?
Yes, they are. So we're just installing a new electronic medical record throughout the corporation. It's called Epic, and it's what you'll see at most major medical centers around the country. The beauty of Epic is that your providers who are in the community also have an account, and they can access your medical record, and it's seamless. So if they see you in their office, they can send us a note, and we can actually have that continuity that we're talking about if they come to the hospital. So.
Yeah, I think that was a large problem earlier, is that you would have a blood count done in the ER, and you'd go to your doctor and say, hey, I went to the ER, and they would draw your blood again because they don't have a copy of the record. But now with what you have been installing called Epic, which is a medical record that's in the computer, patients can go from one office to the other, and all the records are together.
Yes.
So when they go to the ER and they're discharged to one of your clinics, the doctors there can review what happened there?
Correct. And some patients have their own primary care physicians who are not part of our network, and they can access the record as well through something called Epic Care Link, which is their portal into it. So if we have somebody who's coming to us for specialty services, like if they need a screening colonoscopy or if they have another issue, that provider can send us all the relevant information, and you as the provider in our hospital can actually just access it right away.
So it's not just Kings County 2.0, it's like Windows 10. It's the newest,
Right.
The top line of software available. So patients not only are getting a higher level of care like you described with Kings County 2.0, but technologically speaking, they're really 21st century plus.
Yes.
Now let's move forward into this transition of care here. Primary care. Is it available at Kings County?
Yes.
Tell us about your primary care clinics or where patients can access this.
Sure. So we have a huge number of outpatient visits. We have about 500,000 outpatient visits per year in multiple specialties, but most all of that starts in our primary care clinic. They're doing some very innovative things in that clinic in terms of being able to do what we call is like an e-referral or an e-consult. So if somebody's coming to our clinic that needs to have your services, like they have a problem swallowing or they have a problem with their digestion, we can send you a consult while they're in the office and say, what should we do with them? Should we send them to your office? Do you want to see them now? Or is this something we can just treat and let go?
So really expediting the process.
Exactly. And so by doing that, we've been able to avoid an unnecessary visit and have better access to the specialty clinics and also get more immediate care for those patients. So
very, very efficient care, starting from a primary care standpoint, which is all of our viewers need to know that Google is not the place to find the answers to your health questions. Seeing a primary care, prevention is key in healthcare. Kings County 2.0 is preventative care, primary care. Leading to the ER, you're able to admit people, maybe a safer discharge, a better discharge.
Yes.
And I really think it's incredible what's going on in the New York City landscape, and Kings County, which is part of the New York Health and Hospitals Corporation, is stepping up the game, it sounds like. Focusing back into the hospital setting, I know you have a big hospital. How many beds are in the hospital now?
So we have about 630 beds.
It's pretty big.
Yes, and we have a separate freestanding psychiatric hospital, which is about 220 beds of the 600.
You're training people?
So we're training people. We have an amazing psych program, actually. They have, over the years, been able to use lean methodology to make some of the best practices in the country. And so they have visitors coming from different states, some international, and viewing their programs.
To learn more from Kings County.
Correct. And one of their large proponents is involving the community with the care, being able to do exactly what we're saying, which is, make sure that their high-risk patients are seen. They have a mobile crisis unit that goes out if somebody didn't show up for an appointment. So this whole safety net, we're a safety net hospital, but we actually provide a safety net for the patients. And
beyond.
Yeah.
Residents, fellows,
yes, we're
medical students?
Huge training. We have training programs in almost every discipline. Some of the largest emergency medicine residency in the country. SUNY Downstate Medical School is our partner and right on our campus. We train the majority of their students. So it's a really fantastic learning environment as well.
So we're taking care of patients, you're training the future doctors, you're providing incredible comprehensive care, education. I really enjoy talking to people who provide healthcare as a safety net, as you mentioned. And for the viewers out there, a safety net means that you take everybody.
Yeah.
And you really do at Kings County. Inability to pay.
Yes.
Can't speak the language, you find someone to speak the language.
Yes.
The ER, from when I was a young kid, and I didn't even grow up in Brooklyn,
Yeah.
we've known about Kings County. This was the place where people showed up.
Mm-hmm.
And so I think that's great that you were able to come here on the show and provide us with this Kings County 2.0,
Thank
the
you.
next step in Kings County Hospital. So let's learn a little bit more about Dr. Pulitzer,
Okay.
who was before the CMO of Kings County and leading Kings County 2.0.
Yes.
You were a radiologist, correct?
Yes, so I'm a neuroradiologist. So I do a lot of MRI imaging of brain, head, neck, and spine disorders. Before I went to medical school, I was a sculptor, a professional sculptor. And so, so I've had a
So you were a
three-dimensional
sculptor,
career.
an artist, a radiologist, and I think that's really important because what we see more and more, the leadership of hospitals is a physician or someone who trained in patient care.
Yes.
And that's really, really important. So I think that's what's making all the difference for you. And thank you for coming on and talking to us about what is the safety net hospital of our county, Kings County, and looking forward to hearing more about Kings County 2.0. I hope you'll join us again in the future.
Will do.
Dr. Pulitzer,
Thank
really
you
thank
so
you for
much.
coming. Thank you for our interest in our show and hearing more about Kings County Hospital today. You can visit our website, medcastplus.com, and check out our tools and connect with us on social media, or reach us by phone at 718-510-2103. I'm Dr. Braha, and from all of us here at Medcast Plus, stay healthy.